Welcome to Ask Dr. Mingle, a Q&A series from Mingle Health where we take your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and executive chairman of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
Before we get started today, I want to invite our listeners to send their questions for Dr. Mingle. You can leave your questions in a comment on LinkedIn or YouTube, and you can email them directly to us at hello@minglehealth.com. And we have 4 questions today, and all 4 questions focus on the MIPS Value Pathways framework announced by CMS. Our questions today were all sent in by Linda, and they offered us a chance to dive into some MVP explanations and details. So thank you for the great questions, Linda. Our first question from Linda today is, for 2023, if our organization chooses to report one of the MIPS value pathways for one of our specialties, and we also submit traditional MIPS as a group, will CMS grant us the higher of the 2 scores?
Well, thanks, Kyle, and thanks, Linda. Great question. I love your idea of using MVPs early. I think some extra time to make sure you're working out the bugs, that you're recording data appropriately, it's showing up in your data outputs, is great. And I love multiple submissions. Uh, there's lots of good about multiple submissions. It gets more measures in, so it gives us a broader selection to deal with, gives Medicare more data from which to broaden their benchmarks, make it somewhat easier for all of us, and it gives you multiple scoring points from which Medicare can choose the best. There is risk. I'm reasonably confident that the intent of Medicare is to grant the higher of the 2 scores to the whole group. But particularly in the first year of the program, this is the kind of thing that CMS sometimes gets wrong. I expect a lot more guidance and clarity in the next round of rules. The proposed rule for 2023 is due out any minute now. And of course, when it comes out, I'm going to summarize it in my annual proposed rule webinar. My intent from that webinar is to alert you to the proposed changes and the proposed set of rules for 2023 and give you and me a chance to comment on it to Medicare to help refine and improve the final rules that'll be out that are due out on the 1st of November. And of course, I'll follow that with my annual final rule webinar. And I expect also, since MVPs is a big part of 2023, that last become a valid way to submit, then I'll do a focus session on the MVPs as well with all the new rules. So after the proposed rule comes out, we both should be prepared to comment, to fill the holes and correct the errors we see before the rule is finalized. Considering that we may still be in an uncertain position in 2023, I see you have 2 options to manage those specific concerns. One, submit both. If you suffer from the lower score, request a targeted review. And second, if you're submitting through us, prep both submissions. We routinely score our submissions and can submit for you only the best. That might be difficult. Some of the measures on the MVP may not be, if they're new, they won't be benchmarked in the first year, so we may not be able to give you advanced warning of what your score will be on the MVP. But again, I think your thinking is in the right line. Keep that, and we'll refine it as the final rule comes out.
Linda's first follow-up to that question was, what should we expect about the dynamics of mandatory subgroup reporting? We have 10 specialties, and it seems like a monumental burden to have to submit 10 MVPs.
Well, Linda, I agree with your suspicion. I think MVPs is going to be a significant increase in burden for multi specialty practices. For the single specialty practice, uh, the MVPs should, in fact, make MIPS easier. We drop from a six measure set to a four required quality measure set. But with 10 specialties represented in your group, you may be responsible for as many as 10 MVP subgroup submissions. Now, there will be a couple of dynamics that I expect to reduce but not eliminate the impact. First, I expect some MVPs to apply to multiple specialties. In that, I don't. Well, I'm not going to comment on those that are available now. We'll know more after the final rules are out, and that could change. If you have MVPs applicable to multiple specialties, you may be able to lump some of your specialties into a single subgroup submission. Second, I expect a minimum number of providers that are required to form a subgroup. I don't know what that's going to be. It may be as few as two. I don't expect a single physician in a specialty um, uh, to be required to do an MVP. But again, the final rules are not out yet, and they're subject to change every year. So your single provider specialties are likely to end up orphaned from the subgroup MVP submission requirement. Third, I expect there will be many specialties that do not have a relevant MVP, and many individual specialty providers that don't fit their specialty MVP. They have a tiny a piece of that they're a subspecialty, as you will, or subspecialty that doesn't fit. And I haven't yet seen how Medicare proposes to handle these. I expect it to be in the same fashion they handle other orphan providers that um, there's not enough of them to warrant an MVP submission. So I expect that there may be a generic MVP available, or the traditional MIPS reporting. More likely, I think they'll get their scoring from an MVP that's in a related, even if distant related specialty, which is certainly no worse than now when a set of primary care measures will suffice for everybody's quality score. Certainly, be prepared for reweighting of quality points or assignment of quality points generated through submissions, as I said, for another specialty in the group.
Great. So the third question from Linda today is, if we voluntarily report an MVP and submit as a group, can the MVP providers report both ways, or do we have to carve them out so they only report the MVP?
The intent for the first couple of years, and of course, the current timeline is that MVPs are first reportable next year for the 2023 performance year, um, and we're expecting to go to mandatory subgroup MVP supporting in the year 2026. Now that year, I think, is more likely to slip, to be put off for another year or more. I would give it a 50-50 chance of slipping at least 1 year. Um, I don't expect the 2023 first year to slip. I don't see uh, anything really that makes that an advantage to Medicare. So I expect it to be confirmed in the proposed rule, and then again in the final rule. And remember, in the first year, and I believe I'm expecting this for at least the second year, possibly the third year of elective MVP reporting, that the MVP can actually apply to the whole group. Uh, so you might choose a cardiac surgery MVP, and like the MIPS reporting now that applies to the whole group, no matter um, who the measures apply to, the MVP can be the score for everybody. So yeah, I encourage you to submit MVP and traditional, and you can submit MVP for the whole group in this first year, and that's probably better, uh, and expect to get the best score applied to everybody, and be prepared to ask for a targeted review if they fail to do that. Uh, pay attention to the proposed rule that comes out. If they haven't included their plans for assigning scores when there are multiple scores available, be prepared to comment on that before creation of the final rule. I expect when the proposed rule comes out, we'll have a date in September that will be the end date for submitting comments, and they do take those comments seriously, and they do often adjust the final rule.
Linda's final question today is looking at the MVP we intend to submit, we can only report 3 of the 4 MIPS CQM quality measures. Will we have to add the complexity and cost of a QCDR vendor to assure we can choose 4 MVP quality measures?
Great question, Linda. And I'm afraid that my answer is yes. The intent, well, and again, Medicare could surprise me um, in this final rule, or even changing their mind by the next final rule. But it seems clear that they want 4 quality measures. They're giving you a lot of choices of what they are, and they're expecting you to choose 4 quality measures that you can submit with both the um, data completion criteria. So that's right now 70% um, of the data regarding all patients of all insurers. Um, and the measure needs to meet the case minimum, which for all measures that I know of, well, that's not exactly true. Most measures is 20 patients, a 20 patient minimum. So if any of the 4 measures you would like to submit don't hit the minimum, and uh, the case minimum of 20, or if you can't generate a report on 70% of your eligible patients, then you will need to choose another measure. If there is another measure, if there isn't, that would generate the need for an exclusion application, or perhaps a targeted review after the fact, or they. I haven't seen yet protocols for submitting those. You may be able to submit a true denominator and a numerator that's as low as 0, to for them to automatically handle those in some way. But again, we'll need to wait till the final rule is out until we know that. You can expect some industry adjustments to take this on, because obviously, if you're required to do MVPs, and QCDR is required to get up to 4 measures, your 10 specialty group could need to submit the 10 different QCDRs, which creates a monumental burden. Now, already QCDRs are permitted to, and many do, submit uh, registry MIPS CQMs. But again, that doesn't help the fact that multiple specialties means you need to engage multiple QCDRs. Um, we're already beginning the process of reaching out to QCDRs. A weakness that QCDRs tends to have is a limited number of data transfer protocols, and if you can't manage with their protocol, or the redundancy of doing it with multiple QCDRs, then they won't be as likely to help you, or again do it with an enormous cost. So we will be serving as that middleman, that we get all your data and then can distribute it to one or more QCDRs to supplement your submissions. We do have the rights, if we arrange it with each QCDR, to submit their measures. I tend to believe the best way is to give them the data to submit their measures themselves, because the purpose of a QCDR is to further the uh, uh, the aims of the specialty to help improve the care overall. And they can only do that if they have access to a bigger data set. And I think the MVPs may actually help us do that. If you give us all the data and we distribute to multiple QCDRs, um, it can be a boon for the specialty and make it a more attractive, more affordable option for all of you. Now, this also suggests I encourage you for early engagement. We have a lot more to work with if we can tell a QCDR we have this many practices that are ready to give you data through us if you accept this arrangement. So, the best is a provisional contract that says you'll be submitting with us in 2023 if we can do your XYZ QCDR submission. But even a verbal, we're interested. These are the QCDRs that we're going to be liable through. That helps us as well. So we can be reaching out and saying, this is the pricing we want, this is the volume we can bring, this is the value we can bring you. And I love a future that looks more like that.
Well, thank you, Linda, for the 4 questions today and the opportunity to do a deep dive into MVPs. And we hope all of our listeners and you, Linda, found that helpful. If you have questions for Dr. Mingle, you can send them to us directly at hello@minglehealth.com. You can leave them in a YouTube comment, or you can leave them in a comment on LinkedIn. Thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks, Linda, for all the great questions. I want to be helpful. I want this to be useful to you. Don't hesitate to correct my answers, supplement them, share your experience, ask your questions. We can be smarter together.